really are fortunate to be able to have such an expert. Dr. Connie Savor Price, Colorado is not short on experts, but to have been through the COVID pandemic with a local provider who is a national expert on infectious disease. Dr. Savor Price is the Chief Medical Officer at Denver Health. In addition, she's a professor at the UC School of Medicine on infectious disease. She is published, she is funded. NIH and the HRQ and DOD and all of these different people who think her thoughts are important enough to get more of them out there. And we are fortunate enough to have her come and share those with us. So without further ado, I would ask you to help me welcome Dr. Savor Price to the stage.
Hello, everyone, and thank you for having me here today. I'm really honored to speak with all of you and learn from you and tell us, my goal here is to tell you a little bit about what I've learned about value-based care during the COVID-19 pandemic and how important and critical it was to navigating our pandemic and our success in navigating that pandemic. So our objectives while you eat your lunch, first you'll have a little bit of just presentation, and then as time allows, sit down with our host, Carter Kimball, and just have a discussion with all of you about some of our learnings. But first, we'll talk about the COVID-19 impacts on healthcare delivery and just review that. So these numbers are just from our state health department, and I will start by saying that the impact of COVID was far more than what we thought we would be experiencing at the beginning of this pandemic. We had over 1.5 million confirmed cases in Colorado, and certainly more of those cases that were not confirmed. We had about 70,000 hospitalizations in this state due to COVID, and deaths due to COVID exceeded 14,000. So the human toll was extraordinary. And it's been all too recent that we've seen headlines like this in the New York Times from November 2021, just as the Delta variant was starting to emerge. And the headline was, "Colorado hospitals are nearly full as the state battles a growing caseload." And indeed, at that time, many of us were having to turn patients away in our emergency departments or find emergency departments for them in other states. And we were starting to drill our crisis standards of care plans for anticipating that we would not have enough resource for all the people who needed it. And so it was clear in surviving this pandemic, we had to adhere to a number of principles that I think are going to sound very familiar to many of you in this room. So the first principle was that we had to preserve our hospital beds for the sickest of the sick. We had to focus on prevention. We wanted to prevent people from getting infected in the first place through promoting messaging around social distancing. And then as we had vaccine available, utilizing that, pushing that out to our people as quickly as possible in order to prevent severe illness from COVID-19. And as therapeutics and prophylactics came available, we got those out to our patients as well in order to prevent them from needing those precious hospital beds. We had to steward our resource as if our critical supplies would be gone tomorrow, because in many cases, that was a real risk. We were running short on personal protective equipment. We had to figure out ways to extend the supply of that so that we could take care of our patients and keep our healthcare workforce safe. We had to steward precious paralytics used to ventilate people when we would put them on the breathing machine. We had constant shortages of other critical drugs, and we had to be very mindful of how we use these precious resources. And as we had more information about what risk factors were for severe illness, we used our tools to identify those patients to prevent them from needing that hospital resource. We had to learn to disseminate knowledge quickly. This was a completely new infectious disease at the beginning of 2020. And as we learned about how to treat it, we had to get that message out very quickly. And sometimes we would learn things and then find out that maybe we were wrong and had to get a different message out. So it was a lesson on disseminating knowledge and how to do so efficiently and quickly. We had to figure out how to get care to patients outside of the hospital setting. In some cases going to their home, some cases going to community centers, to places of worship. And then we had to collaborate. People who we would normally compete with, other hospitals that we would normally compete with, we had to work together. We had to figure out how to navigate this pandemic together for our state and through the continuum of care, involving other stakeholders, long-term care facilities, pharmacies, mental health institutions, et cetera. And so much of how we were able to navigate this really was, many of those lessons are familiar to you because this really is the model of value-based care. And what these researchers from the Duke Margolis Center found is that those who were primarily further along that continuum of value-based payment systems were much more likely and able to innovate and to respond to the needs of this pandemic than those who were primarily on a fee-for-service model. You may remember early in the pandemic how many of the providers, when elective surgeries were canceled, many systems had to lay off people in order to be financially viable, whereas those of us who are on more of a value-based payment system were able to innovate a bit more and roll with the punches, if you will. And so I'll describe some of those successful innovations and models that we widely used in the pandemic. So the first and the most talked about for sure is the use of telehealth. And as you recall, and as we still see today, telehealth use exploded with the onset of the COVID-19 pandemic. Volumes were extremely low pre-COVID. Less than 1% of patients ever used these services prior to April of 2020. And even my own institution, who've been talking about this for 10 years, on a dime, within a week, got telehealth services stood up, and many others also. The line, as you can see from this graph of time versus volume of appointments, almost a vertical line in April of 2020, where we peaked in our telehealth use. And then by April of 2022, that use has come down about 60%, but is still very much present in our systems now. But we need to be mindful that there is a digital divide, and that we learned during the telehealth, during the pandemic, that telehealth did not increase access equally to all. And even in the United States, which is quite resourced, we know that there's a lot of variation in access to the internet. So if you look at broadband availability and a national rate calculated about 85%, the states in the bright blue, including Colorado, had higher than the national average access to broadband internet. In Colorado, that served us well. The states in the Navy, however, had lower access to broadband services, and that made telehealth a bigger barrier for those states. But in addition to just having access to the internet, for telehealth, you have to also consider language barriers, other foreign languages that might be used by the patient, their health literacy, their available technology to be able to access the internet, and just connectivity speeds. And so that was something that when we deployed telehealth at Denver Health, we were mindful of this. So many of our patients do fall in some of these groups and had these challenges. And so we had to do some outreach sessions to make sure that some of our patients could be educated on virtual care and how to utilize them when they didn't have the ability to present to our clinics. This education session was done by our ambulatory care services group at the Denver Housing Authority. But I also want to remind you that virtual care is so much more than just a video visit. And in fact, from this slide, the graph on the left shows video visits as a percentage of our total visits, and they still make up less than 5% of our total visits. Many of our visits are audio only, and some of that is due to ease, but some of that's also due to patient preference. There are some patients who really do not like seeing themselves on screen, and so audio visits are also frequently deployed. The use of e-consults and e-visits is another mechanism, and what we've learned during the pandemic and even before is that, for some specialties, you really don't need an in-person visit. For instance, in my specialty, infectious disease, a common consult question might be, what antibiotic do I use for this very resistant urinary tract infection? Well, the fact is, I don't need to see the patient physically to answer that question and to provide advice to that care provider. So what I can do through an e-consult mechanism is go into my electronic medical record, review the information that the primary care physician has provided to me, review all the labs, and put in a formal consult without having to make the patient come in and sit before me in order to give an answer that I could give just as well without having to do that. Virtual check-ins is another modality I'll talk about in the next slides, but that's also a very powerful tool where you don't necessarily have to have the patient come to you. You can go to the patient via virtual means. Remote patient monitoring can also be used to keep a closer eye on patients, and particularly when maybe they don't quite need hospitalization, but you need to keep a closer eye on them. Mobile apps are a great tool for patients to allow them to be more involved in their own health care. And then, of course, there's the use of the chat function that is increasingly being used to communicate with providers. So I want to mention our virtual hospital at home program. That was another tool that was deployed during the height of the pandemic when we were running out of beds. We needed a solution. And challenge does create innovation when you have the right structures in place to innovate. So our virtual hospital at home involved seeing an eligible patient, maybe in clinic, who has some concerning findings, and maybe they've been diagnosed with COVID-19 and they need oxygen. But maybe that oxygen could be given at home. So they're assessed for their risk, they're set up with that home oxygen if needed, and then they're given a packet of tools, an oral thermometer, a blood pressure cuff, a pulse oximeter, a notepad, a pen, and some instructions. They're trained on how to use these devices in clinic before leaving that clinic appointment, and they're instructed to record their vital signs 4 times a day. Twice a day, a provider in our clinic or working from home if needed could call and check in on that patient, review the vital signs, review their symptoms, and then decide, can they continue the virtual hospital at home, or do I need to bring them in physically? And so often, we were able to avoid use of a hospital bed because of these check-ins that we were able to do virtually. And within 10 days, typically these patients would be discharged from the program, if not sooner, just as if they were in the hospital. And I'll show you these data that show on the x-axis time and the y-axis volume or percentage, and the blue bars are the in-house positive cases per day, and the orange line are the number of patients on our virtual hospital at home program. And you can see as the pandemic went on and as we were stressed more in the pandemic, our virtual hospital at home utilization increased accordingly, very much in proportion. And at the peak, we would have about 40 patients a day on the virtual hospital at home program. Imagine that in the peak of the pandemic, being able to preserve 40 beds for a patient who needed it more than somebody else. And that was really critical to surviving the pandemic. And it's a tool we can use now. But so much of the uptake of innovations like this will depend on how we pay for the service. There are other digital health arrangements, of course, in value-based care that we can look at. And the new pandemic that we're dealing with now and have been for some time is the behavioral health pandemic. And that is something that lends itself beautifully to this technology, and we can do more of that. I described the use of subspecialty consults. In many cases, you can do these through e-consult mechanisms and through virtual care. There's also the chronic management, and I described some of the technologies you can use to monitor patients at home using these digital applications. So there's a lot of opportunity that we still can deploy in this. Using telehealth in urgent care is also a really powerful tool that we've recently implemented at Denver Health, and that can avoid a patient having to come into the ED or urgent care. And saves a really precious resource. One example I'm really proud of is really being able to call our virtual urgent care when you find out, when you test at home for a positive COVID test with a home test. You can call our virtual urgent care. They'll assess you and be able to then just send Paxlovid if you qualify. To your home through pharmaceutical delivery services. So it's a really great tool that we were able to innovate with during COVID, and I think has much application beyond that. So some key takeaways, well, yes, virtual care is continuing to evolve. It is a tool that's a keeper, but the uptake will depend on reimbursement and how providers are paid. We know that continuing to rely on all in-person modalities is archaic, and hybrid models are likely the model of the future. We do need to acknowledge, though, that there are disparities that remain to be addressed. So there is also a focus on prevention that we saw during the pandemic. And we heard the message frequently of washing hands, maintaining social distancing, and having a lot of campaigns to get out to our public to send this message about how to prevent. But we also then learned of data. We had new knowledge about the efficacy of vaccines in preventing severe illness from COVID. And in these data, good science demonstrated that 2 doses and then 3 doses of vaccine was incredibly effective, between 85 and 99% effective in preventing mechanical ventilation and death. And that was true in the early pandemic, during the Delta variant, and even during the Omicron variant, even when the vaccine match wasn't quite as good in the later time of the pandemic. But very useful. So we needed to get it out there, and the Biden administration did make it available to anyone who wanted it. And then our challenge was to take that vaccine that was available to all and get it to our public. And I think through a great collaboration with our state health department, with our local public health departments, with our hospital systems, Colorado ended up with a very high vaccination rate that helped get us through this pandemic. So that focus on prevention, it's key. I want to shift now to the importance of health equity and some of the lessons learned from the pandemic in this domain. So the World Health Organization defines health equity as is the absence of, or I should say, is health equity is the absence of unfair, avoidable, or remediable differences among groups of people, whether these groups are defined socially, economically, demographically, or geographically by other dimensions of inequality. Health is a fundamental human right, and health equity is achieved when everyone can attain their full potential for health and well-being. And increasing health equity benefits all value-based care stakeholders. And this is definitely true, or especially true, when you're dealing with an infectious disease. An infection doesn't care who you are. It does not obey borders. It does not stop at county lines. It does not stop at your neighborhood border. So equitable outcomes need equitable delivery systems. And this starts with our community, and then those institutions within the community, and then we can look within that to define patient subpopulations and individuals who we need to reach out to make sure that they're getting access to all the things that they need to have access to. And I want to show some real live true data from Denver during this pandemic. This is a point in time, I believe these data were obtained right around the height of the Delta pandemic, or the Delta wave. And so this shows hospitalization rates per 1,000 persons by Denver neighborhood. And you can see in Denver, there were inequities in our COVID hospitalization rate. So let's look at this a little bit more. What about in cases of COVID-19 in families of color in Denver? Well, this might be hard to read, but if you look at the blue line shows groups of people that comprise the percentage of the Denver population. So the very bottom group is our white non-Hispanic, which is 54.8% of the Denver population. And then going up a couple of rows, our Hispanic or Latino population, which is 29.3% of Denver. The orange bar shows the cases of COVID in Denver among those groups. And when you see the blue and orange not be the same, we have an issue. So clearly, at this point in time, the Hispanic or Latino population was clearly being affected disproportionately. Now, I'll say in later waves of the pandemic, that gap started to close. But initially, this is what we were seeing. And so how do you tackle that as a health system who's trying to keep people out of the hospital so that we can take care of people? Well, you can use your data. You can use your big data. Look at neighborhoods and zip codes with elderly populations that have high hospitalization rates, high death rates, high testing positivity, and low vaccination rates. And here is what we found in our analysis. And what this did for us is then these neighborhoods that are highlighted in red, that is where we sent our people to go vaccinate, to go educate on prevention measures. So here's some more data. This is taken from February 2021. And it's looking at the vaccine administration and our demographics. And what this shows is something similar to what we saw in the previous slide. So the pink bar that you see is the vaccination rate of white non-Hispanics as of February 28th, 2021. And the bar around it, again, represents the percentage of population in Denver, or Colorado in this case. And you can see that this population seemed to have a higher rate of uptake and access to the vaccine compared to our Hispanic population, which disproportionately had a lower vaccine administration access. So again, these data can help target where we need to make an intervention, how do we close these gaps. And one way we were able to do this was being able to engage our federally qualified health centers in COVID vaccine distributions. The areas of the map of Denver that I showed you that had a lot of inequities in hospitalizations, that's where our clinics are, and that is where we needed to get vaccine. And it was very effective in reaching these neighborhoods. But nothing more effective than going to the place where the people gather, where they are, in a place where they're around trusted people who will increase access and increase uptake to vaccination or other health services. So this is a picture of our mobile health unit that was deployed all through Denver in an effort to reach these populations and help us navigate through this pandemic. The last thing I want to talk about is just the unique partnerships and the unique collaborations that happened during this worldwide pandemic. This is a publication in the New England Journal of Medicine Catalyst called Innovations in Care Delivery. And the title of this article was a commentary, I should say, Physician Executives Guide a Successful COVID-19 Response in Colorado. And I want to show the names on here. J.P. Vallon, our lead author, was a CMO at the time of SCL Health. And Shauna Gully, the next author, was a CMO at Centura. Ben Keegan, Boulder Community. Catherine Perkins, the former CMO of Banner Health. Myself at Denver Health. Bill Neff, UC Health. Gary Winfield, HCA, and Darlene Taddy of the Colorado Hospital Association. We were meeting twice a week at minimum, sometimes every day, on the phone, dealing with this pandemic for almost 2 years. And just a couple of quotes I want to read to you. When you start working together and stop competing, some of the powerful things you can do. So the CMOs effectively worked together to ensure that Colorado hospitals had sufficient resources, including staff, critical care medications, inpatient and intensive care unit beds, PPE, mechanical ventilators, and to accommodate the surge that was predicted for our state. The collective goal was to bring major health systems together to identify issues, share best practices, align on difficult decisions. Visitor policies was one. Provide guidance for when there was either no guidance or rapidly changing guidance on how to address these unprecedented challenges. One example, when Denver Health was really low on gowns, my colleagues at Centura, orchestrated by Shauna Gully, found us some gowns that they did not have a use for because of the way they were constructed and fit for their staff. And same with N95 masks, where certain hospitals didn't fit to that particular mask. We were able to share PPE and help all of us get through the big waves of the pandemic. And early on in COVID, this was we have a success story to share through this collaboration. So we could, by July 2020, we could boast clinical outcomes for COVID-19 patients that were better than the national average, including lower overall mortality rates, lower average length of stay, and fewer patients requiring mechanical ventilation. And a lot of this was through that rapid dissemination of knowledge, sharing knowledge with each other, communicating what we were hearing from our front lines, what works, what doesn't. A solid example here, if you look at the box in the lower left-hand corner, is the percent of COVID-19 patients requiring ventilation. What we were hearing from our front lines early on was that these patients actually measure really low in oxygen saturation by pulse ox, and yet they look clinically fine. It's super weird. And what we learned from them is that, you don't put a breathing tube in some of these patients. You have a lower threshold or a lower O2 sat that is used for intubating patients, and their outcomes were better. This became a national best practice, but it's something that we were able to see in Colorado very early on, just from talking to each other and getting on the phone, and instead of competing, we were collaborating. So finally, I just want to examine some of the learnings for our improved post post-pandemic world. And so we know that relationship reform in the form of collaboration and in the form of having our patients be able to use digital technologies when they can, being able to remove the points of friction and waste, working together better. We can change our business model to achieve better outcomes, better experience, and lower costs, and that's the triple aim. And that is something that is very true in a post-COVID world. And lessons for the payer sector going forward is that the value-based fundamentals really are something that helped us survive the pandemic and will continue to help us navigate a post-pandemic world. We still have hospital capacity issues. That actually hasn't gone away. We have staffing shortages. We have everyday emergencies. And so what we learned to help us navigate the pandemic will have us better equipped to navigate a post-COVID world. We know that extending flexibilities for virtual health services is important. And we need to rethink benefit designs with these principles of value-based insurance. I think we also have to figure out how to better incent people to continue using and even improving on some of the technologies like virtual hospital at home that I described. How do we pay for that to incent people to use that capability more? And how do we get people to collaborate more? So the movement is here to stay. The desire for reform has been growing for decades, as has the economic imperative, and COVID really amplified that urgency for change. So with that, I guess if we have a couple of minutes, Carter, we'll take questions and have a little discussion.
Great. So while folks are finishing up, please keep eating. We are going to have floating microphones. If somebody has a question, please, the more food dribbling out when you ask it, the better. There are actually bonus points being awarded. I'm happy to start, and I think that there's so much to kind of touch on, but I don't want to waste the opportunity of having an infectious disease doc without asking the vaccine question. What's the future look like for the vaccine? Does it turn into a seasonal thing like a flu shot, or just kind of that crystal ball as to where we're heading?
Well, it remains to be seen. We do have the new booster available, of course, that better targets the newer variants, the Omicron subvariants that have been causing most of the infections recently in Colorado and throughout the United States. But already we've had much decreased uptake of that vaccine. I don't know if it's vaccine fatigue. I don't know if there's just less emphasis on it now. But these are things we need to continue pushing. And then whether it becomes seasonal, I think will depend on what happens with the rates of COVID that we see probably this fall.
So to kind of dovetail from that prevention step into a treatment step, you already mentioned an innovation that was just brought on by data sharing and collaboration around how to treat folks. What does the future of treatment for COVID really hold for us going forward?
Well, we're in a place now where we have some options. So we have Paxlovid, we have monoclonal antibodies, we have vaccines that are better targeted to prevent it altogether or to prevent severe disease. So I think treatments will continue to evolve. They're certainly not perfect. We've heard a lot about rebound infection with Paxlovid. Monoclonal antibody can be a bit difficult to administer, and it's resource intensive. So there's still more work to be done on that front for sure.
I'm going to keep going until somebody I've got a long list of questions. So where do you think, when we talk about value-based care and arrangements relative to response to a pandemic or to an emergency, how critical is that going forward? I really like the frame of thinking through this is a tool to combat kind of times of need, is this movement along the value-based chain. So I would ask you to pull on that thread just a little bit.
Yeah, with telehealth arrangements?
Yes.
Yeah. So I think that's one of the biggest successes during the pandemic, is really getting all of us to stand up some form of telehealth. And there's so much more we can do. But we still have challenges with how it's paid for. Even with the virtual hospital at home, which we had great outcomes, we had great patient satisfaction. You know, if you can admit somebody to the hospital, provided you have the bed, you're going to get paid better. And how do we fix that? How do we address that? Ultimately, that's the incentive that needs to be aligned. You know, when you're in a stressful situation like COVID, where you don't have capacity, well, it's a little bit different. But these are things we need to continue to work on.
On that line within the kind of technology space, what are some of the areas that you see that are maybe potentially the biggest gaps for that type of movement to more virtual care and things like that? Is it data sharing? Is it the actual technology platforms for the visits themselves? Is it care management? Is it population health? Just some of those areas and where you think there's more needed.
Yeah, well, there's so much more technology that we could leverage that we just aren't leveraging now. And I think some of it is just upfront costs. You know, there's a lot of monitoring devices that are available. There's communication ability with the patient in their home to providers. Some of us are using that, but that does require, it has an upfront cost to it. And then it requires the people to be monitoring it on the back end. So there's still, and for some institutions like my own, some of that's going to be cost prohibitive. You know, you have to really plan for it and to invest. For others, maybe not so much. But you know, right now, I think that is, it's the cost really is the biggest barrier. And of course, what we talked about with some people just don't have, they have a lot of barriers to being able to use these technologies, whether it's their health literacy language or just even internet access. Those things still exist.
So on the vein of, and this will be my last question, then I'd be happy to open it up to others. On the vein of that kind of lack of investment, right? We know where we want to go. Maybe source for capital up front is needed in order to make real progress. Talk a little bit about some of the investments that Denver Health has made, that maybe others could start making, that states and payers could look at, really in terms of investments around equity.
Yeah, well, I think it's really just understanding the problem, you know, first and foremost. So utilizing our EHR, our EPIC data, which is really has some powerful information in it. We did learn as we were trying to go forward with understanding our population is that on intake, we weren't asking the right questions to find out about their true demographics, you know, race versus ethnicity. And so the first thing we did was modify that so that we were asking the right question to get the answer that we were seeking. And then with that, we can then further segment the population and where are the opportunities, who aren't we reaching, and how do we correct some of these disparities. We've also made a lot of efforts in looking at our clinical algorithms. It's really, I hope, it's just shocking, I know to some of you to hear that many of the medical algorithms ingrained in our practice, programmed into our EMRs, are kind of archaic and racially biased. So the first one we looked at Denver Health was how you calculate kidney function, which is a creatinine clearance. And there was a race correction to that algorithm that when you really dug down on the research, it wasn't very data-based. And what we were finding is that the populations, particularly Black population, were being under-screened for kidney failure and as a result of their high blood pressure. And so we were intervening later in that population. we've gotten rid of that algorithm and reprogrammed it so that we no longer take that into account. But looking at all of these algorithms, super important. They're not always quite as data-based as we would like to think.
I think that's a great example of just kind of self-awareness within your own house, right? Not exactly just so dependent on what others are doing or waiting for others to make a change, but really being able to take a look inside. Questions from the audience? I've got one over here.
Good afternoon. You know, as we look in the value-based care environment and we're really trying to reduce the total cost of care, I was very intrigued by your virtual hospital at home model. And how do you see that? If you could wave your magic wand, where would you see that in 5 years? And do you think that's a major part of the solution? And that would be one question. I'll take the opportunity to ask the second question. The collaboration that you did with all the other hospital systems and leaders on the medical side, I think was groundbreaking. And it was evidenced by the New England Journal of Medicine article. Where do you see that going, and in what other fronts would that be, I think, low-hanging fruit in the next few years? So two questions there, if that's okay.
So the virtual hospital at home, I think, has great opportunity in some of our very protocolized conditions that we might take care of in a clinical decision unit type environment or an observation environment, where there's a very defined clinical condition that really it's just monitoring. There's not a lot of intervention. It's monitoring, and if it's heart failure or asthma exacerbation, I think some of that can be converted to the home environment. So I see a lot more opportunity. Pneumonia's another good one, where you just can monitor a little more frequently in their home environment. And when needed, bring them right into the hospital, where maybe you can even direct admit them. But lots of opportunities for using technology to allow care at home. The collaboration piece, I do hope we see that continue. With this group of CMOs, some of whom now have successors that are part of our group, we still have our calls every week, actually twice a week. And most of it is around preparing for the next emergency, whether it's a pandemic or another all hazards event. We've talked a lot about how to be better equipped for that. But I do think there's opportunity to do more in, what if we had, centers? This is a pipe dream, but what if there was one center that did spine surgeries, and they're really good at spine surgeries, and therefore their outcomes are terrific and infallible, whereas another center maybe took on another type of complex procedure or condition. I don't know if healthcare in America is ready for that or will ever evolve to that, but wow, if I could create a perfect system, that's what it would be.
She gave you the magic wand, so you get to create whatever you want.
She did say I had a magic wand. Okay, that would be my system.
Quickly, the follow-up to the virtual, the at-home piece. Do you think, and that can be a combination of the two, but do you think it's more important than for reimbursement to respond to a virtual at-home situation with upfront dollars for investment to establish workflows and technology and some of those things, or would the more important cog be the ability to reimburse, right? Almost that prospective versus retrospective piece of it, and how to get things started. How do we make progress in that from kind of both angles?
Well,
again, you have a magic wand, so you get to say whatever you want.
So I am sitting in a room full of policy experts, payers, people who know so much about this part of it than I do. I am just a simple ID doc at the end of the day. I guess I'd put the question to this room. What would be better? I mean, we would enjoy more upfront investment, but what is the better way to pay for something like that? What would you find that your hospitals would respond more to? Is there anyone out there who has a thought on that?
Somebody can take it on, surely.
I know. I think there's somebody else who probably knows the answer to this.
It's reimbursement.
Yeah.
Our current system is built on reimbursement
Yeah.
strategy methodology. So delivery system reform follows reimbursement strategy.
See, that's the opposite of what I would have said, but this is why you do what you do. But, you know, I want to highlight the way we look at it, or the issues we're facing, and you guys know how to incent that, and you guys know how to affect that behavior. So, thank you.
Well, with that, I think we are at time. If you would please help me thank Dr. Savor Price for her comments and her time today.